Okay, I'll invite Dr. Purendra Bhasin now. He'll be talking on lens-based refractive procedures, ICL and clear lens extraction. He is a prolific refractive and cataract surgeon and is well known in the international and national circle for his talks and comments. Dr. Purendra Bhasin.
Thank you, Dr. Bharti, for giving me this opportunity to be in your course. And I will be focusing on ICL and clear lens extraction because they are also a very important part. So ICL or phakic lens is a biocompatible lens between the iris and the natural lens of the eye. It is reversible and does not involve the removal of the corneal tissue. Better option for unsuitable candidates for corneal refractive surgery. Coming to the clear lens extraction, it involves removal of the natural lens and replacing it with an IOL to correct the patient's refractive error, just like a cataract surgery we do. But this surgery is done for the purpose of refractive correction, not for the purpose of cataract removal or lens opacity removal. And it especially is beneficial for those with presbyopia or having a high refractive error, whether myopia or hyperopia, or the patients who are not suitable for the corneal refractive surgery. The advantages over the corneal refractive procedure is that it preserves the corneal integrity, its reversibility and adjustability is the forte. Wider range of refractive correction, like we can correct high myopia or very high hypermetropia, and is suitable for older patients as it addresses presbyopia and future cataract development, and we can use multifocal, trifocal or an EDOF IOL, and there is a reduced risk of dry eye as compared to the corneal refractive procedure. Coming to the phakic lenses, the indications has very well been detailed by Dr. Bhupesh. It is like any other refractive procedure case. It is for 18 years and above when the patient's refraction is stable. But phakic IOL, we generally do it for the LASIK rejects, although we can do it for the low myopes preferentially. That is the choice of the surgeon or the patient if you explain them. And LASIK rejects are the cases with high myopia when the cornea is thin, less than a 5 micron thickness, when there is a dry eye, large pupil size, excessively flat or steep cornea. The contraindications are the presence of lens opacity, pseudo-exfoliation, zonal or instability, presence of a coloboma lens, or any previous corneal or ophthalmic surgery which has been done. Any other ocular pathology like glaucoma, intraocular inflammation, corneal degeneration or dystrophy or macular pathology or neovascularization. Like in any other refractive procedure cases, we do a complete workup. But the two important things which are useful in this procedure for the ICL or phakic lenses is that our AC depth internal from the back surface of the cornea should be more than or equal to 2.80 millimeter, excluding the corneal thickness, and the corneal horizontal wide to wide measurement has to be done, and our endothelial cell count should be more than or equal to 2000, and rest of the investigation as we do in all the refractive procedure, complete, uncorrected, best corrected, visual acuity, cycloplegic and manifest refraction, etc., etc. And angle should be not be less than 2, grade 2, and it should be wide open. So coming to the first case, this patient is a 23 years old female and with a thickness pachymetry of 549 and 558 microns, and anterior chamber depth is 3.16 in right eye and 3.12. We planned for toric ICL in her case. This could be done by the surface procedure also, although the power was 8.5 diopters with 1.25 diopter cylinder, but surface procedure produces haze, as has been said by Dr. Bhupesh also, erratically. So PRK can be done possibly in this patient, but we prefer doing the toric ICL, and patient had on post-operative day 1 the vision of 6.9 and uncorrected vision of 6.6. You can see this. The surgery is very simple, and it takes almost or less than 5 minutes to perform. The lens comes in a BSS, and this is a front loading cartridge system, and with the help of soft tip plunger we keep the lens in a cartridge, and from the front side we pull it in the barrel of the cartridge, and then it is pushed inside the anterior chamber, which is filled half with viscoelastic, and then the lens is aligned to the axis, desired axis, and wound hydration is done, and this is the end of the surgery. It takes less than 5 minutes to perform the surgery if the patient is comfortable, and the technique is very easy, simple and rewarding. Another case, 42 years old patient who was a high myope, and minded this is a presbyopic age group, so we performed surgery for this patient, and keeping one eye under correction, instead of 10.25 correction, we did a spherical correction of -9 diopters in this eye. So this left eye will be helping for the near vision, and the right eye for the distance vision. So this way, with the monovision correction, by under correcting it, we gave the patient a good help the patient for the good distance and near work. And this way we have done almost 16 eyes in 8 patients, patient age ranging from 41 years up to 52 years, and they were not having any cataract, and all variety of myopia was there, right from 4.5 diopters up to 10.25 and 13 diopters and 19.5 diopters, and all these patients with one eye under correction and leaving the 1.5 diopters of myopia for the patient, and one eye full correction, we managed to give good vision to them, and they all are quite satisfied. And then coming to the part of keratoconus management, this has been dealt by my previous speaker, so I will skip this part, but we have to, this is a nomogram which we follow. We optimize the cornea in a short. Day 1 post-operative, patient's vision improved to 618, with phenol improved to 612, and similarly with some refractive correction of -0.5 with 0.75 cylinder, vision improved further. So the best corrected vision, which was 24 before, was now 624. Patient was highly satisfied with his surgery. And last case which I would like to share with you, 22 years old female came to us with a plus 12 diopters of hyperopia, and she had an amblyopia in this eye also, and IL power was 49.34 diopters and 49 diopters in the other eye. So we did a monofocal eye lens of 40 diopters, and post-op day 1 uncorrected vision was 6.9 part and 6.9, and bit later on the vision improved to 6.9 again, and for the rest of the residual refractive error of plus 2 diopters, because we instead of 49 diopters IL power, we implanted a plus 40 diopters lens in this patient. So for the residual refractive correction we did PRK, and she improved to 6.9, 6.12 in both her eyes, and she is very happy, but she requires near vision correction. So so clear lens extraction in presbyopic eyes, we can opt for multifocal, trifocal lenses and or EDOF lenses, but definitely the issues of PCO is there. And for the IOL power selection, we use a Barrett Universal 2 formula, which is the standard practice now in all our cases. Various studies have come, and in this particular study which has been published in 2023, there is the refractive lens correction in 78 eyes on 39 patients. They say that the refractive lens correction is there possible, and bilateral implantation of panoptic IOL, and it gives a good correction post-operatively. Another study where they have compared refractive lens exchange with the phakic intraocular lens, they say that phakic intraocular lens is better. And the last one, which is the study which was there, they say that the refractive lens correction is equally good as compared to the phakic lens, and it is cost effective also. So to conclude, phakic IOL is the procedure of choice in all young patients and in LASIK rejects, whether it is Indian or imported. In elderly myopes, phakic IOL is the choice with undercorrection, or with a newer presbyopic correcting ICL, we can opt for that also in these with some riders in it. We can go for it because it has been recently launched in India. Clear lens extraction is a choice opted with retina clearance. That has to be very, very important, and it is mandatory. And in the presence of PVD, we can go for clear lens extraction, or if there is a early cataracts present, or on eye tracy, if the lens index is high, then there are aberrations which are lenticular, which is causing the poor vision. Then also we should plan for refractive lens exchange or clear lens extraction. Coming to the hyperopes, LASIKs and when we cannot do LASIK or we cannot do phakic lens, then clear lens extraction is the choice of procedure in all age group patient. And in high hypermetropes, definitely clear lens extraction is the procedure of choice. Thank you. Thank you for your patience.